right, everyone. This is a little strange because I am talking to an empty classroom where I normally am talking to a bunch of students here. And I am recording this video for you guys for week 4. For week 4, on the syllabus it says chapters 18, 19, and 20. And I just want to confirm that we are just going to cover chapters 18 and 20 for the sake of time, and also for our little kind of crazy schedule that we're having with me being away next week and then the Thanksgiving break and so forth. So just to give you a heads up, for week 4 we will only be going through chapters 18 and 20, which means you will only be tested on those 2 chapters for what you're responsible for that week. Okay. Now, chapter 18, just to let you know, goes over different cardiac functions, whereas chapter 20 goes over the different types of shock that can occur. But these 2 chapters are, and do, fall under the category as cardiovascular disorders. Okay. So, we'll get started with chapter 18. We will talk about mainly in the beginning about coronary heart disease and the process of arthrosclerosis and the different clinical manifestations that can happen from there, okay? So, just to get started, when we talk about coronary heart disease, keep in mind that we are talking about an insufficiency of oxygenated blood that is getting to the heart muscle tissue itself. And what happens here is that when there is a decrease of oxygenated blood getting to the heart muscle tissue, we know that yes, this could lead the tissue into a state of ischemia that we discussed week 1. And also just keep in mind that there's other clinical manifestations and signs and symptoms that can come from that. So the things that can happen could be angina pectoris. Angina pectoris just means chest pain. So that is definitely a symptom that can come from this. Myocardial infarction, so if there is enough of, or I should say, an extreme amount of lack of blood flow, it can now cause the muscle tissue to die in that area and cause the muscle of the heart not to contract, which obviously will put that person in a state of a heart attack. Dysrhythmias, it can definitely throw off the heart rhythm itself, and also heart failure. Okay, so if the heart is completely out of sync with cardiac output and just the rhythm and just a whole bunch of things, it can put it out. And also sudden cardiac death. Okay, so it can get to that point. Now, the first thing that we're going to talk about in detail is something called arthrosclerosis. Arthrosclerosis, as you know, most of you guys know this very well, in this situation is when there is lipid plaquing that can pool up in the artery. When we have lipid plaquing that can pool up in the artery, obviously this will block blood flow and therefore block blood flow that will get to whatever tissue or organ it needs to get to. And in this situation, if we ever have plaquing that pulls up in a coronary artery, this is a bad situation because this can now lead this person into possibly having an MI. Okay? So we do want to go through the pathophysiology of what happens with arthrosclerosis and the formation of how this occurs. So, with arthrosclerosis, it can lead to cardiac ischemia, obviously through making that thrombus formation, also causing the vessel to go into a coronary vasospasm that we talked about in chapter 15. These vessels can go into vasospasm, and any type of dysfunction in the endothelium, okay, which it will cause. Now, before I get into train of thought. Okay. Well, before we get into the actual pathophysiology of the whole arthrosclerosis process, we do want to go over, okay, the different types of lipids, okay, and what does this mean, okay, with these lipids. Now, as you can see here with this PowerPoint, this chart here, I should say, we do have something called chylomicrons. We have VLDLs, ILDLs, and LDLs and HDLs. Okay, so I'm just going to go over a few of these and mainly stick to LDLs and HDLs. Now with chylomicrons, just to let you know, these are present especially after we eat a meal. So if you eat a meal, what will happen is when the body breaks down these different fats, it will now have certain amount of fats that can flow through the bloodstream, and they do flow through the bloodstream in the form of chylomicrons. So as you can see, we have 85% triglyceride, 5% cholesterol, and that's normal. That's normal once after we eat a meal. So if a person's having, say, for example, a fasting blood glucose testing, and you see chylomicrons floating around, a bunch of them, that's not a good sign. Okay, so we really shouldn't have that floating around if the person is in a state of fasting. Now, the other thing here that I just want to go over quickly is the composition of LDLs and HDLs. Now, LDLs, they do have 5% triglyceride, 55% cholesterol, and 20% protein. And when you look at that chemical makeup there, or the composition, 55% cholesterol, okay? So these are pretty much, this type of molecule is very high cholesterol, meaning that it's not a good thing to have a bunch of those floating in the bloodstream. Hence the reason why LDL is considered to be our bad cholesterol, okay? So in that situation, you don't want patients to have high LDL levels. You want them to have low LDL levels. Now, when you look down here, when we talk about HDLs, high-density lipoproteins, they are made up of 5% triglyceride, 20% cholesterol, and 50% protein. So most of them are made up of protein, okay, and that's a good situation there, because what will happen here, you want to have high HDL levels. Now, another reason why you want to have high HDL levels in the bloodstream is because what HDL will do, HDL will actually take cholesterol and bring it to the liver so it can get broken down into digestion and circulation. So please keep in mind that HDLs will actually pull that cholesterol out of the bloodstream, out of circulation, and actually now take that cholesterol and have it synthesized or broken down, not synthesized, excuse me, broken down in the liver. So that's one of the things that is important. Now the problem is when we talk about LDLs, okay, and why they're also bad. The reason why they're bad is obviously because of the cholesterol, but the reason why LDLs are bad is because LDLs will actually bring cholesterol and these types of fats to the periphery of tissues. So it does not get broken down by the liver or any other source in the body. It'll actually take that cholesterol, bring it to the periphery of tissues, and then it can actually sit there at the tissue level. When it sits there at the tissue level, this causes obviously a lot of damage to that particular organ. So this is why we do not want to have high LDL levels, and we want to have high HDLs. Now, just to also let you understand that HDL levels, when they are, well, to bring your HDL levels, I should say, up, or to get them elevated, exercise is actually one of the best ways to raise HDL levels. And then obviously, yes, telling the patients to make sure that they alter their diet and decrease eating, obviously, foods that are high in saturated fats and things of that nature, which we already know that. So just to give you that background about HDLs and LDLs. Okay. Now, this slide, just to kind of go over with you, we talked a little bit about, okay, the difference between HDLs and LDLs. So we said HDLs, high-density lipoproteins, definitely take cholesterol out of the system and definitely bring it to the liver so it can clear out and break it down. Now, make sure you go through this slide. Make sure you go through this slide, which I kind of already talked about, so you can just read that. Now, this is just the same picture. Now, this slide here, okay, what this talks about, it now talks about the formation of how we make a lipid plaque in a vessel. So I have to break this down for you. And I'm sitting here with my notes. I don't need them right this moment. So, say for example, we have a person that is eating a diet that's high in saturated fat, so someone that's eating, say, In-N-Out all the time, Popeyes or KFC or whatever type of greasy food, even any type of burger place, okay, or anything like that, or Dunkin' Donuts, which, oh wait, we don't have Dunkin' Donuts over here, that's an East Coast thing, sorry. Or Krispy Kreme, we have a Krispy Kreme. So in any event, you get the picture. So people that are having a diet that's high in saturated fats, things that are definitely made up of a lot of butter that is used in certain foods and things of that nature. So keep in mind that when these individuals have a diet that's high in saturated fats, and not only that, some other risk factors for these individuals for arthrosclerosis are people that have sedentary lifestyles, people that are overweight. Also keep in mind that sometimes people that are diabetic can also be at risk for arthrosclerosis. And also any type of pre-existing vascular issues or cardiovascular issues can also predispose a person for arthrosclerosis. Anything that makes the blood stagnant can put these people also at risk, okay, in conjunction with, yes, eating a lot of fats and having these lipids just kind of pulling through the bloodstream and making the blood actually slow down even further. Okay, so in any event, say they have this diet that's high in saturated fats, okay. Yes, these patients, if you have a lipid panel done, cholesterol will be elevated, maybe triglycerides, LDL levels will be elevated, so all of those things. And I'm actually going to go over, I didn't pull it out, I have it with me, but I will go over the laboratory values that you guys do need to know for this particular chapter as well. Okay, so there are some laboratory values that are important here. So, say for example, they do have this diet that's high in saturated fats. These lipids are flowing through the bloodstream. Now what happens here is that the way this atherosclerotic plaque forms, it forms due to an injury that happens in the vessel. So I don't want you to think that it just forms and then all of a sudden, oh, it just sticks and, you know, just magically just sticks to the wall. But it happens because of an injury. So what we mean by that is what happens if there's an injury. Say for example, we have a piece of a lipid. Lipids are not nice and round and circular. They do have sort of jagged edges and a little crazy shape. So what will happen here is this sort of abnormally shaped substance will flow through the bloodstream. It will sort of nick or cause an injury to the endothelial wall of the vessel. When it causes that injury, obviously now there's a break, and it will now start to signal the immune system to bring immune cells to that area, okay? So endothelium becomes permeable and now recruits leukocytes. So once we have leukocytes and everything coming to that area, now this is going to start this whole process. So what happens is the LDLs will get unsedation occurs with oxidation by epithelial cells and macrophages. Okay, so what does that mean? That means that when those macrophages come over to try to eat and get rid of the lipid, because it's recognizing the lipid as something that's not foreign to the body, which is a good thing, but the problem here is that when it comes over to attack that lipid, it actually goes through a process called oxidation. So to actually oxidize because of the chemical makeup of lipids along with the macrophage, and unfortunately the macrophage can't eat it away, but it'll actually make now a bigger sort of cell or a bigger mess. And so what happens here is the oxidized lipids are damaging to the endothelium and smooth muscle cells, and they stimulate recruitment of macrophages to the vessel. So when it recognizes that it oxidizes and makes this bigger mess, now we're recruiting more macrophages to the area, which is now going to make a bigger mess, okay, if that makes any sense. So when macrophages come to the area here, they will engulf the lipids, and when they engulf the lipids, because they're not really breaking it down, but instead of breaking it down, it actually now turns into something called a foam cell, okay? So foam cells are released, and they do release inflammatory mediators and growth factors, attracting more leukocytes. So the body is going through this process, but is continuously putting it in this sort of immune or inflammatory response. So now, once we have this large foam cell is actually now there at the endothelial wall, and what makes it get stuck there, okay, now I don't know if they explained it that well here, but what makes that foam cell get stuck to the wall, okay, and keep in mind this foam cell is now pretty much a lipid plaque, so to speak. So it's a lipid mixed with a macrophage. So what makes this get stuck to the wall is that obviously over healing time, or over the process where the vessel tries to heal, because we keep in mind the healing process is still taking place, you have this foam cell, but then you have endothelial cells that are trying to grow and regenerate that vessel that was broken. So when it grows and regenerates, it will grow and regenerate pretty much around that foam cell, and now it makes this lipid plaque fixated to the wall of the vessel. So now you have epithelium that actually grew over the lipid plaque, okay? So now it's nice and solid, okay? And as they say here, excess lipid debris accumulate in the vessel wall, and then we do have that solid, nice lipid core, okay? So the other thing here that we do have to talk about is once we have this solid lipid core, keep in mind that it can stay there, okay? And obviously when it stays there, this is what we call a thrombus. But then it can also, over time, break off, okay, and flow through the bloodstream, and this is what we call it an embolus. Now, how does it break off? What will happen is you have this lipid plaque, blood is flowing through, and then all of a sudden, it can maybe weaken the core or maybe weaken the outside of that lipid plaque, and then it will break off. Okay, so just the stress of that blood flow can break it. So vulnerable plaques have a large lipid core, they have a thin cap and high shear stress, meaning the stress from the blood flow. Okay, and those are the things that can make it break off. Okay. Now in your book, they have these nice little diagrams here that goes over everything I just explained to you about how that process of forming the lipid plaque occurs in the vessel wall. Okay, so you can review that. It is in your book. I'm not sure exactly what page it is, but the table is in your, the figure number, excuse me, is in the PowerPoint, so you can look it up. There is also a nice video, just to let you know, on YouTube, and I'll tell you what it is, although I believe Mrs. Felton is going to show it to you next week. But in any event, the video is on YouTube, and it's called Arthrosclerosis, and it's by, I guess the author or whoever posted this video is called Nucleus Animation. Okay, so it's called Arthrosclerosis by Nucleus Animation. Nucleus Animation is one word. So this company, they put out pretty good videos, and they did put a nice video of arthrosclerosis, and it goes through that whole breakdown as to what happens and everything. Okay, so I would tell you to look that video up. And for the sake of time for this video, I don't think it's necessary to show a video on the video. Now, coronary heart disease. Okay, so we have to continue on talking about what happens with ischemia and when there's a lack of blood flow, and how this actually presents as far as clinical manifestations. Okay, so when we talk about ischemia here, ischemia occurs when oxygen supply is insufficient, and not only just insufficient to that tissue, but when it does not meet metabolic demands. Okay, so if that tissue and organ is ready and waiting for that oxygenated blood, but it doesn't receive it, then obviously it will now start to go in a state of dysfunction. So critical factors here, we do have a term called rate of coronary perfusion. And what does that mean? Coronary perfusion just means the rate of blood flow. So what happens here is that if we're talking about the coronary artery, we need to know, does the coronary artery have an exact amount or the proper amount of rate of blood flow that it needs to have in order for our tissues to get the adequate amount of oxygenated blood. Okay, so rate of perfusion is extremely important. The other thing here is myocardial workload. Okay, so is the myocardium itself, is the muscle, heart muscle itself, is it working too much? Is it working not enough to pump out this blood that needs to get to the tissues that we have that need this sort of oxygenated blood? So we need to make sure that the myocardial workload is also up to par. Now, the other things that can alter or cause ischemia, we can say, or cause, I should say, excuse me, coronary perfusion, or alter coronary perfusion, obviously if we have an arthrosclerotic plaque. So obviously if there's some sort of plaquing or blockage, that will obviously impair the rate of perfusion or the rate of blood flow. Also, another thing that can form is platelet aggregation or thrombosis. So keep in mind, and we talked about this a little bit with chapter 15, that platelets, or 14, platelets can actually pull up, okay, and make pretty much a thrombosis, okay, so platelets can pull up and make a clotting situation. We also talked about, in chapter 15 too, vasospasm. So sometimes these vessels can go into an extreme vasospasm, stay there, and obviously cause the issue of blood flow. Failure of autoregulation by microcirculation, what does that mean? That means, if you remember from maybe physiology or anatomy, that we have the microcirculation. So if you know what microcirculation means, this is arteries to arterioles, to capillaries, to venules and veins. And if you remember that microcirculation, that it goes in that order as far as flow, okay, through circulation. Now, what they're saying here is that for some reason, if that order, or I shouldn't say the order is off, but if for some reason the rate of blood flow gets diminished in one of those parts of the order, then that's also going to cause an issue there. So if there's an altered microcirculation. And then poor perfusion pressure. Okay, so what does that mean? That means that when this blood is circulating through the body, okay, perfusion, blood moving through, but for some reason the pressure is not enough to get the blood going to where it needs to go, then obviously that's going to also be an issue and cause ischemia. Now, we do have to talk about two different types of coronary syndromes. We do have a chronic syndrome that we're going to talk about, and then also we're going to talk about an acute syndrome. Okay. So with a chronic syndrome, this is with slow progression, and this is most of the times due to, and I would highlight this, a stable arthrosclerotic plaque. Okay, so this is a stable plaque that's sitting there in the vessel stuck. And then what happens here, yes, it will alter the rate of perfusion. And so what will happen here is that the heart muscle itself will not get the adequate amount of blood that it needs. So therefore, it could lead this person into an ischemia. And the term that they use here is a fancy term, ischemic cardiomyopathy. All that means is that there is a lack of blood flow at the heart muscle. Okay, that's all that means. And then this person can also get what is called a stable angina. Okay. Now I'll go over with you what stable angina is. And stable angina pretty much is an angina that happens when a person has a blood flow that gets to a critically low point. Okay, or coronary blood flow that gets to a critically low point. And so what happens here? Yes, they do get this extreme chest pain. And they do have some other names for angina, but I'll go over that with you in a second. Because we're going to go over the different types of angina. Okay. So, in acute coronary syndrome, what we have here are acute changes in a plaque. So what can happen here is that this plaque can now change in its shape, the morphology. Maybe it'll get larger. Maybe it will just kind of move somewhere and it gets stuck, and even the thrombosis. Or maybe it could be at a stage where it's starting to break off or something like that. So in this situation, this is more indicative of what we call a myocardial infarction when there is an acute coronary syndrome. Okay, and then sometimes it can be just an unstable angina. And so the difference between this is that unstable angina means that this person is not getting enough blood flow to the heart muscle tissue itself, but it's not enough, it's enough to not cause damage, okay, or break the muscle tissue down. But when we have a myocardial infarction, this means that there's not enough blood flow getting to the tissue or the heart muscle itself, but then also what happens is that the heart muscle will actually start to break down and damage itself, and the muscle gets deteriorated, okay, which is what happens in MI. Okay, but we'll go over that again in a little bit. Now, we do have three different types of angina, okay, and I do want to go over this, and I do have some notes here that I want to give you, some side notes that you would be taking down, or if you're watching it, when you're watching this video. And I do have some medications that we're also going to add to this, okay, how they treat these different types of angina. Okay. So, the first one we have is stable angina. So stable, also known as typical angina. And they also have a third name for this type of angina, which is called classic, okay, classic angina. So as I told you, this type of angina is present when the coronary blood flow gets to a very critical level, okay, so it's reduced in a critical level, causing this type of chest pain. Now, just to let you know, this type of chest pain can be relieved by rest. And the medication that is used for this is nitroglycerin, okay, nitroglycerin. And what nitroglycerin will do, nitroglycerin will actually cause the vessels to dilate, okay, open it up, and it will also decrease the workload on the heart, okay, so therefore relaxing the heart, opening up the vessels to now decrease this whole sort of acute situation, okay, or pain that they're having. Now, the next one we have is something called presmental or variant angina. So they say that this one is defined as unpredictable attacks of angina, okay? So what will happen is you can be sitting in your chair, and this actually happened to me one time, and I'm quite sure a lot of people have this feeling where you just all of a sudden you get pain and it's debilitating and it grabs you, okay? This is that type of angina that just comes out of nowhere, okay? And so not to say that, you need to rush to the hospital, okay, because you are having a heart attack, but all this is saying is that the coronary perfusion is so little to a point that it's actually now starving the muscle of that blood, and so it will go into this sort of spasm or state, okay, from that. Now, this type of angina, presmental or variant angina, is actually common in people that do have arthrosclerosis. Okay, so it is common in arthrosclerosis. And just to let you know what the treatment is, they do have a different treatment for this one. Although I think they can give them nitroglycerin, but they can also give them calcium channel blockers. Okay, so calcium channel blockers. So this is another medication that can be used. And calcium channel blockers will actually inhibit smooth muscle contraction. So it'll actually stop the muscle from contracting, it'll relax it, and get that blood pumping to the area it needs to. Now, the last one here is something called unstable or crescendo angina. So with unstable or crescendo angina, what happens here with this type of angina, this is intermittent chest pain that actually gets worse. So say, for example, patient has a chest pain that maybe is at, let's say, a pain scale of maybe 3, then it gets to a 4, 5, 6, 7, 8. And so the pain just actually gets worse, just more intense and actually more grabbing. This type of angina is very common with patients that are undergoing an MI. So when patients are undergoing a heart attack, they do have this unstable or what they call crescendo angina, meaning just getting elevated crescendo or higher. So with this situation, when patients are having an MI, just to kind of give you some clues with it, yes, they will have the chest pain, but not all patients that have a heart attack kind of do this, okay, like they show you on TV. But what will happen is that sometimes patients can also have profuse sweating, and that sweating comes from the fact that the sympathetic nervous system is getting activated. It's getting activated because of the fact that it recognizes that it's not getting enough blood flowing to the heart muscle tissue. So what the body is going to do as a compensatory mechanism is get the sympathetic nervous system elevated, okay, so it can now increase the heart rate and get everything pumping, okay. So the side effects from having that sympathetic activation is, yes, profuse sweating. Another thing these patients can have is that the neurological impulses will also get activated. So what will happen is that, yes, sometimes they will get the shooting pain, and they may get radiation to the jaw area, maybe down the left arm. Not sure if all heart attacks sort of go along the same, I don't think everything is textbook. I know they used to say that females get it to the jaw area and males get it down the arm or whatever the case may be. But in any event, Just keep in mind that these things do happen as far as the radiation and definitely the sweating. Okay? That can also happen. And patients will also describe that the type of pain that they're having with this type of angina is like a choking sensation, or somebody sitting on their chest, or an elephant sitting on them, or whatever. So it's like a squeezing type of feeling. Okay? And so the treatment for this will be nitroglycerin. Okay, so they have nitroglycerin as a treatment, although I'm quite sure they can use calcium channel blockers as well. So, the next thing here we're going to talk about is the difference between an unstable angina and an MI. Okay. So one thing I just want to point out here, we already know, yes, what could possibly cause it with arthrosclerosis and then all the risk factors for that. But then what happens here is that unstable angina, when a person has what is called a partial occlusion, this is when they're just having an unstable angina, just that chest pain, okay? Whereas when there's a full occlusion, okay, this person is definitely having an MI, okay, so that's the difference. And through diagnosis from an ECG and biomarkers, this is used to determine which are they having. Okay, are they having an MI, full-blown MI, or are they just having an angina? So let's go over this. Now this chart, I definitely want you to know, I always ask questions, okay, from this chart. And I like this chart because it really breaks down, okay, what is going on with your patient, and as far as the difference between unstable MI and MI, okay. Now, so they have here, very nicely, presentation, working diagnosis, okay, so when you do your testing of an ECG, cardiac biomarkers, and then, okay, from getting all of this, what is going to be your final diagnosis? So, signs and symptoms here of cardiac ischemia. So say, for example, this patient may have chest pain, okay? Maybe they do have a history of, saying, having a high cholesterol, okay? Possibly maybe a history of arthrosclerosis in the past. And maybe they have tried to control this and it's not controlled. Now, what will happen here is if they have all the signs and symptoms of cardiac ischemia, what should be the working diagnosis is what is called an acute coronary syndrome. So you don't want to treat it right away, but you definitely want to put them in that category and then build from there with your other test results and so forth, what's going to happen, and then come to your diagnosis. So what happens here is that, and not to get into so much with EKGs, but if you recall from physiology, okay, normal EKG, you have the P wave, P, Q, R, S, and T. Okay, so if you remember just the basic